Dear colleagues, welcome to my hospital at Ranaghat, West Bengal, India. In this case, the challenges are the patient is under topical anesthesia and uncooperative. The cataract is soft and the pupil is small. I have taken up this case for surgery. Let us see how the case has been managed. By this time, the main incision has been made, and this is a side port on the right side of the main incision. And now, an air bubble is being injected into the anterior chamber. I want to stain the anterior capsule of this cataract with trypan blue dye underneath this air bubble. And this is the dye. Trypan blue 0.06%. And now this is adrenaline, preservative free adrenaline. I want to see if the pupil dilates little more. And after injecting a bit of adrenaline, the antechamber is thoroughly irrigated with BSS. And we see that the pupil has dilated quite well. The pupil was initially about 4 mm. Now it has become almost 6 mm, or at least 5.5 mm. And this is enough. If this much dilatation remains throughout the surgery, I should not have any problem. But see what happens. I have injected viscoelastic substance, and then I'm going to make one side port on the left side. Yes, this is about 2.5 clock hours away from the main incision. The patient is under topical anesthesia and patient is not cooperating at all, moving her eyes a lot. Now the side port on the right side was very small. I'm enlarging that side port to some extent. And now capsular access. In this case, I have used a 26 case bend needle to do the rhexis. With Itota, I may touch the iris. So I used the needle and I'm going along the margin of the pupil to get an adequate sized rhexis. In some places it is going little beyond the pupillary margin, and ultimately the rhexis is complete. And now see what happens during hydrodissection. As soon as I try to do hydro and I touch the pupillary margin, the pupil again becomes small. It is about again 4 mm. Since the cataract is soft and the pupil is small, in presence of these double challenges, I always take help of some device. In this case, I am going to use B-hex pupil expander. After injecting viscoelastic substance in the anterior chamber, I introduce the B-hex. The device goes totally into the anterior chamber, and at on go, I tuck the leading flange at 5 o'clock. Now I go through the right side port and tuck the flange at 1 o'clock. And now I go through the left side port. This is B-hex forceps, opens vertically, very easy to manipulate the B-hex ring. And this is the flange at 10 o'clock. And this is the hexagonal shape of the pupil. The size of the pupil is about 5.75 mm, and this size will remain because the dilating device will keep the pupil size constant at this level. Now see, I am burying the tip and then I am in irrigation now, staying there. If I apply vacuum, I'll remove lens mass. But if I stay there and just support the lens mass, I can slice the nucleus with the chopper. Here, I just stay there and slice the nucleus with the chopper. And here, using very low vacuum, I could emulsify this piece of the nucleus. Phaco power required in this case was very less, about 40% or 30%. Vacuum used was about 350 millimeter of mercury, and flow rate is 35 ml per minute. This is the other heminucleus. I'm just holding it very softly with low vacuum, and I emulsify and remove it. Yes, the nucleus is managed. In this case, the cortical cleanup part has been edited. You can remove the cortex either by bimanual IA or coaxial IA or by a Simcoe cannula. Then I inject viscoelastic substance and implant a hydrophobic acrylic intraocular lens in the capsular bag. And now we have to remove the B-hex device. After positioning the intraocular lens in the capsular bag, the B-hex forceps is taken again, and see how the B-hex is removed. Go through the main incision, inject some more viscoelastic substance, go through the main incision with the B-hex forceps, and the flange, which is at around 3 o'clock, which is above the iris, is held. It is pulled centrally, and again it goes towards the 5 o'clock, and see what happens. The whole device comes in the anterior chamber, and now it is held just in front of the main incision, and it is gently pulled out. And now the viscoelastic substance that has been used has to be thoroughly cleaned. I used a Simcoe, and now I am using the irrigating probe of bimanual IA for irrigating out the viscoelastic substance from anterior chamber, from the capsular bag. After thorough cleaning of the viscoelastic substance, the side ports are hydrated and a final lavage is done, and the case is concluded. Thank you very much for watching. Hope this video will give you some tips to manage soft cataract with small pupil.